per se, and it is not associated with seizures, nausea, or vomiting. And there is a drooping of the eyelid noted since 3 weeks, which has no diurnal variation. It is limited only to the right side. And he also has a double vision. The second image always appears laterally and diagonally upwards in related to the object, and the margins are blurred, and no pain on the ocular movement. No prior episodes and no prior surgery related to the eye in the past, and he denies any sort of addictions or substance abuse. So in examination, his vitals, he was hemodynamically stable with a BP of 160 and a pulse rate of 86 and respiratory rate of 20 per minute. And general examination revealed no pallor, icterus, cyanosis, clubbing, or pedal edema. His cardiovascular and system was normal with a normally heard first and second heart sound. And his respiratory system examination showed bilateral normal vesicular blood sounds with the soft abdomen. Examination of the central nervous system had a clinical findings. His right eye had complete ptosis, and there was only downward and outward gaze, and all other extraocular movements of the right eye are absent. And his pupils were dilated, however, it was very sluggishly reactive to light. And the left eye was completely normal, and no other focal neurological deficit. And his fundoscopy, bedside fundoscopy, was normal. So with this, the syndrome complex of the feature suggesting a oculomotor nerve palsy, right? And we looked for whether pupil is involved as per. Here pupil is involved and with no other cranial involvement, suggesting a syndrome complex of right isolated oculomotor nerve palsy. I wish to move to the anatomical localization we made clinically and how did we work up the patient. So coming to the anatomical localization, we can see look over the course of the oculomotor nerve, which arises from the midbrain by its oculomotor nerve nucleus complex, which contains the oculomotor Edinburgh-Westphal nucleus. So when the nucleus is affected, the patient will have ipsilateral third nerve palsy with contralateral hemiplegia or paralysis termed as Weber syndrome, or if it is their coriform movements, the patient will have Benedict syndrome, which means that the oculomotor nerve, after arising from the oculomotor nuclear complex, traverses the midbrain, come across the red nucleus. At this point, if the lesion is there, then the patient will have this coriform movements. And after the crossing of the red eye, there is a partial decussation of the fibers within the nuclear level itself before coming out of the midbrain. And if it is patient is having ipsilateral third nerve palsy with contralateral tremors, that is known as the clot syndrome. So after passing the midbrain and coming out into the subarachnoid space, it crosses in between the cerebellar peduncles, in between the superior cerebellar artery and the posterior communicating artery. So lesion in this site is mainly by the aneurysms of such arteries, causing pupillary dilatation and paralysis of the extraocular muscle action. After this, it crosses the lateral wall of the cavernous sinus along with the third and the along with the fourth and the fifth nerve, where it is mainly compressed by the ICA aneurysms or the cavernous sinus abscesses. After this, it crosses the superior orbital fissure, where it divides into the superior ophthalmic superior nerve and inferior oculomotor nerve and supplies the extraocular muscles. So I would like to, with this description of the anatomy and its course, I would like to ask, where do you localize the lesion in this patient? Please join me in the slide. Left eye of the patient is not involved and pupillary action is affected. Pupil is dilated and sluggishly reactive to light. Thank you for the responses. So further delineating the lesion in this patient. In this patient, all the both the pupil and muscles are involved. So obviously the division is at the superior orbital fissure. So before the superior orbital fissure is the lesion we can expect in this patient with clinical localization. So with this, we are ruling out the superior orbital fissure. The part of the nerve after entering the superior orbital fissure is ruled out. So this part is ruled out. Second, the left eye is not involved. At the level of nucleus only the crossover occurs. So here also nucleus is ruled out. Other contents of the superior orbital fissure are uninvolved. It is only due to the third nerve involvement. So superior orbital ruled out. So we have the part of the oculomotor nerve where it transfers the interpeduncular fossa and the cavernous sinus. So I clinically localize the lesion to the interpeduncular cistern or the cavernous sinus. Coming into the etiological diagnosis, this complex is gradually onset and it is slowly progressive. I keep my infiltrative differentials in the first line, like sarcoidosis, vasculitis, or malignant infiltration, or giant cell arteritis. Then I thought of compression either due to the malignancy or aneurysm. And the least I thought of infection like a brain abscess, meningitis, or a tubercular arteritis. So looking into the his infectious panel, his initial total blood counts were moderately high, mildly high with 14,800 total counts with a differential predominant of neutrophils of 78%. And his CSF analysis did not show significant to the infection, and his expert TB in CSF also turned negative. So after this, we went with the MRI sequence, in which the gross MRI per se couldn't get any conclusive diagnosis. So we specifically asked the drive sequence of the MRI, in which to look for the nerve and its pattern and thickness. That picked up the diffuse thickening and enhancement of the right oculomotor nerve, the interpeduncular cistern along the lateral wall of the right cavernous sinus. So this was further studied, and it was radiology and neurosurgery was involved, and this was further concluded as a nerve sheath tumor, because this is an isolated finding and the patient does not have any features of other associated symptoms. So we have a infiltrated nerve now. So to look for the autoimmune inflammatory conditions and to the malignant thing, the appropriate for his age, appropriate infiltrative conditions were looked for, and those were all negative. IgG4, sarcoidosis, and those were all negative for this patient. So considering the nerve sheath tumor, nerve sheath is the layer of the myelin and connective tissue that surrounds and insulates the nerve fiber, and these tumors are very rare in incidence, 0.3 to 0.4 per 10 lakhs population, and it could involve either the central nerve or the peripheral nerve. This could be benign or malignant. Benign lesions we usually describe were neurofibroma, schwannoma, perineuroma, nerve sheath myxomas, ganglioneuroma, hemangioblastoma, whereas it could be it also has a malignant potential of malignant neurogenic sarcoma or malignant granular cell tumor. So what is the significance in general population? If the patient has schwannoma, this is more commonly seen in neurofibromatosis 2, and if it is neurofibroma, it is more commonly seen in neurofibromatosis 1. And if it is so, the incidence of malignancy transformation is higher than the general population. And if it is a malignant tumor, it has very poor prognosis, and it has only 5-year survival rate of 40 to 50%. Coming into the oculomotor nerve sheath tumor per se, it is extremely rare. We went across various literatures to know further about this, in which literature showed only 60 cases of reported isolated oculomotor sheath tumor, and of which most were intracranial schwannomas. So what are the treatment options available? This is the surgical resection. This could be radiosurgery or microsurgery, like stereotactic brain surgery also. But however, this point, both the treating team and the patients will have a dilemma, because this post-surgery, the patient has a high risk of complications like complete paralysis or involvement of injury to the nearby structures also. So we looked into the oculomotor nerve tumors per se and how it was managed, in which after the surgical resection of the tumor per se has showed recurrence of the lesions or worsening of the condition in 77% of the patients on a long-term follow-up. Stage they did not progress to the complications, and 5% we couldn't trace out. The most recent surgery related to the condition is the stereotactic radiosurgery, in which the article studied has showed that stereotactic surgery per se has showed multiple improvement in the multiple symptoms. Almost 75% of the patient has improved with the facial hyperesthesia, and 65% has improved with the ptosis after the surgery. But then later, after the discussion, there is a approach subtotal resection of the tumor, because the oculomotor nerve per se is a very, very fragile nerve, and if any minimal injury can cause the paralysis and nerve injury progression. So subtotal resection of the tumor is the preferred condition, preferred surgery available everywhere now. So coming to our patient, no cutaneous markers of the syndromes were found, and no familial history also, and radiological features were all no features suggestive of malignancy. Like the tumor is very slowly growing historically, and it is very confined to the nerve sheath tumor, not encroaching the other parts. So it is isolated. Discussion between the treating medical team and the patient family occurred, after which the patient is planned for the subtotal resection in an elective manner. So whenever we come across isolated cranial nerve lesion, consider nerve sheath tumor as a rare possibility, because this may be a syndromic, and if the syndrome is identified, this could be a clue to identify the syndrome. If it is a syndromic associated, there is 10% lifetime risk of malignancy. Thank you.
Thank you, Dr. Sivaranjani. Any questions or comments? So after this, what do you think is the closest differential in your case among the infiltrative nerve lesions? You're thinking of schwannoma, is it? And when is the patient posted for surgery?
They wanted a time, ma'am. They were discussing.
Okay.